So good morning, everyone, and thank you, Dr. Himadri, for giving me this opportunity to be your co-instructor. And I'll be talking about the conventional technique of this beautiful surgery, that is scleral buckling. So, scleral buckling is also referred to as a conventional or external retinal detachment surgery because we use a surgical material that is an explant which is sutured outside the sclera to give an indent in the sclera so that we can oppose the retinal pigment epithelium to the neurosensory retina and attach the retina. So I'll be talking about the various steps of conventional retinal detachment surgery. Uh, it starts with conjunctival peritomy. It is the first step and also a very important step because we have to do a very clean peritomy so that we don't have any problem in the end closing it. And a good peritomy and a good closure prevents further infections, later on infections, and also buccal exposures and extrusions. After doing a good peritomy, we have to sling the rectus muscles or bridle all the four rectus muscles. Care has to be taken while bridling the muscles, especially the superior rectus and the lateral rectus, so that we don't bridle the oblique muscles also. After bridling all the four muscles, the next step is one of the most important steps, that is the localization of all the breaks by intraoperative examination. When we see in the OPD, it's very easy to see, but suddenly when we come to the OR and try to see under intraoperative, when we try to do intraoperative examination, it's sometimes completely a different picture because you suddenly realize what all you could see in the OPD is not that clear in the OR. So a thorough examination of all throughout the retina and marking all the breaks is very, very important because that will define the success of your surgery. Once you have localized all the hello, hello.
Yes,
Yes,
doc,
sir.
it is
Yes, sir.
audible.
Continue.
Yeah.
Audible, go
So
ahead.
once you have localized all the breaks, then we comes the treating of the breaks. The most common and most popular method is cryotherapy. Cryotherapy should be applied while observing the fundus directly with an indirect ophthalmoscope and using a cryoprobe in place of a scleral depressor. So there are some disadvantages of cryotherapy also, like dispersion of the pigment leading to PVR, a choroidal congestion and hyperemia, which can cause some hemorrhage when we try to drain the SRF. Also, there can be a breakdown of blood ocular barrier leading to cystoid macular edema and exudative detachment if we do excessive cryotherapy. But a good cryotherapy in moderation is almost doesn't have any much side effects. So what is a good cryotherapy? How do you cover it? You have to cover all the sides of the break. Like there's a large horseshoe tear, so the anterior and the posterior border and the horns. And from the horns area, take the cryo laser till the ora, so that there's a complete chorioretinal adhesion up to the ora, and it prevents further extension of the breaks. A fresh cryo mark will look like slight whitening of the retina, and it should cover whole of the break on all sides. It's very important to cover the break completely and not leave it on some side, because then there will be inefficient chorioretinal adhesions. An old cryotherapy scar is mainly a scar, and you can hardly even make out break in that when there is a complete chorioretinal adhesion. Photocoagulation can also be used as a method of chorioretinal adhesion. It is delivered through laser indirect ophthalmoscopy. The advantage is that it has a very fast onset of action. The adhesion starts occurring within 24 hours and carries less morbidity, but can only be applied after SRF drainage or to the breaks in the attached retina. As we know, photocoagulation will not be possible even if there is small amount of SRF present around the break. So cryotherapy still remains the gold standard for the chorioretinal adhesions in a buckling surgery. Then there are various buckling materials present. Most commonly used are the solid silicone rubbers that we use. They can be in the form of encerclage or symmetrical and asymmetrical segments. Silicone sponges are also there, which can be used radially. They use nowadays, they are not used that frequently because of the risk of extrusion is more in the sponge. Hydrogel implants used to be there by Mira, but they are now not available. They have discontinued since last 20 years. So mainly two options are there: the solid silicone rubber and silicone sponge. And selecting the proper buccal material and the proper buccal implant is very important also for the success of the surgery. Now, these implants or the scleral implants are suture to the sclera. So a proper suturing is also important. So each and every step is, I'll say, more important than the previous one. So we usually use monofilament nylon or polyester to suture the explant because of their properties like durability, biocompatibility, and ease of handling of them. The suture bites are oriented parallel to the long axis of the implant. That is, if we are putting a radial implant, then the suture bites have to be radial. And if we are putting a circumferential implant, the suture bites have to be circumferential. It's very important to keep the distance between the two bites greater than the width of the implant, because when we tighten the suture, the sclera has to partially envelop the explant so that implant can create some indent inside the eye. When we use a needle, we usually use a spatulated needle. That is, it has a flat superior and inferior surface and sides are the cutting edges. This decreases the risk of a perforation of the sclera. While a cutting needle which has superior and inferior cutting edges can lead to even the perforation. So a spatulated needle is always better for passing the scleral sutures. The placing of the buccal now is the next step. We have the placement of the buccal, and the buccal that is required depends upon the breaks. The buccal indent has to cover all the breaks and other treatable lesions in the retina on all sides at least by 2 mm. So if it is an anterior buccal, we may go ahead with just an encerclage, but if it's a posterior break and a large break, segmental buccals are required. Now there are different techniques of placing the buccal. We can just like shown in the picture on the left side, we can use just a 360-degree encerclage, a buccal with an encerclage, or a radial sponge with an encerclage. So all these methods will vary from patient to patient depending upon the number of breaks, the placement of the breaks, and the size of the breaks. So after we have put the buccal, next comes the subretinal fluid drainage. Now some people they tighten the encerclage after the drainage, and some people tighten the encerclage before the drainage. I prefer to tighten the encerclage before the drainage so that complete indent of the buccal is present inside, and also the fluid which is in the periphery, in the area of buccal, is pushed back so that it gives a larger area, larger space for drainage. So subretinal fluid drainage is a dreaded step, I'll say, because most of the complications that usually occur, the most dreaded being the subretinal hemorrhage, occurs in this stage. Some people prefer to do a non-drainage surgery, some prefer to do a drainage surgery. What are the rationales of subretinal fluid drainage? One, it decreases the intraocular pressure and thus achieves a good buccal height. Also, it reduces the subretinal fluid and facilitates the closure of the breaks. So various indications of subretinal fluid drainage are if there's a bullous or a chronic detachment, in high myopic detachments where the RPE function is not very good, in inferior breaks. If patient is a non-glaucoma, then drainage helps because it lowers the IOP and prevents the washout of the optic disc. When no apparent retinal break is found, these days usually we don't even do buccal surgery when there is no retinal break found. But if you have to do a buccal surgery in such cases, then drainage should be done, so that because after drainage the retina falls back, the folds open, and you are able to see some breaks also, and also if there are multiple breaks. Selection of the site of the drainage. So SRF is drained in an area where there is sufficient fluid to enter the subretinal space safely. And this is the reason that I tighten my buccal band initially, because it pushes the fluid back and there is a further increase in the subretinal space. It should be avoided in the areas which have been treated with cryotherapy, because cryotherapy causes congestion of the choroidal vasculature and increase in hemorrhage. And 3 o'clock and 9 o'clock positions have to be avoided, where feasible nasal quadrants are preferred. The techniques are mainly two types: the cut down method and direct needle entry. After fluid draining the fluid, their IOP goes down, and there are few methods which we can use to increase the pressure, because hypotony will cause decrease in the hypotony will lead to subretinal hemorrhage. So keeping the pressure well is very important to prevent this occurrence of subretinal hemorrhage. We can use either BSS, air, or gas. The complications of drainage, we have already said that subretinal hemorrhage is the most common and dreaded and mostly caused by the hypotony after drainage. Then perforation, retinal incarceration, endophthalmitis are the various other causes. Now, the advantages of scleral buckling in young patients, especially where there's a crystalline lens, and therefore accommodation is I'm just finishing this, my last slide now.
Yeah, if you can come to the concluding slide, doctor.
Yeah, it's the last slide only. And it gives a 360-degree support. The equipment is also, cost is lower. Complications, we have already discussed during the presentation. So thank you. I'll say buckling surgery is one of the most beautiful surgeries for the retina. And if the case is selected properly, there's nothing like that. Thank you.